Okay. Very good evening to all doctors. It's my pleasure to welcome all of you for this scientific feast, our webinar. Uh, and with great pleasure, I would like to introduce our respected faculty for today's webinar, Prisha Mandirwar. Dr. Saab is MD, DGO, FICUG. Dr. Saab is consultant obstetrician and gynecologist from Mysore. Dr. Saab is former professor and HOD of OBG JSS MC Mysore, past president KSOGA 2015. Dr. Saab has been organizing chairman of KSOGA conference Mysore and with a very special interest in the area of GDM and HDP. And Dr. Saab is a master trainer in PPI, UCD and GDM. So with that note, I would once again welcome Dr. Amrisha Banditwad and all the participants who are logging in today for today's webinar for this learning on scientific session on GDM, tackling GDM at its root. We would begin with a short AV on our website, Shield Connect. Chitrala, can you run the AV? Shield Connect is our web page. As you can see, it's a website wherein it's a knowledge sharing platform to connect patient care, especially in the modern day practices. Connect to doctors, international, national. You can share blogs, and also in the field of gynecology, pediatric care. Uh, you can connect to all the faculties across the country, and we have uploaded our webinars, which are almost now to the tune of 300 plus. Past webinars, current webinars are already in place, as you can see. And we have our faculty KOL list, and Dr. Amrisha is one of them. Our key opinion leaders, Dr. Saab is there. Thank you, Chitrakala. So we look forward for connecting all our respected doctors to this website of our Shield Connect. With that, with great pleasure, once again, I would like to hand over the session to Dr. Amrisha Vanderwad, please. Over to you, sir. You
Yeah.
please share a screen. Yeah, definitely.
Thank you so much. I can start?
You can start,
Sir,
sir.
yes, sir.
Yeah. Good evening, all of you. First of all, I would like to congratulate Shield Healthcare for their immense interest in the academic activities of the doctors and making them and giving them an opportunity to update their knowledge. Very nice work they are doing. I am very, very happy with the Shield Healthcare. Coming to today's topic, tackling GDM at its root. We know
Sir, you have to share your
that
screen, sir. Your
yeah,
screen share. So you have to share your screen.
it's not coming.
Yeah, it's not coming, sir.
Now it's coming.
Yeah, full screen, sir. Make it full screen, please.
Yeah.
Perfect, sir.
Now it's there.
Yeah, it is visible, sir.
Okay, I'll start again.
Yes.
First of all, good evening, all the friends. I would like to congratulate Shield Healthcare for their immense help or academic activities for the doctors to update their knowledge about the current diseases and then the knowledge, changing knowledge. Coming to today's topic, tackling diabetes, gestational diabetes at its root. We know diabetes is one of the major health problems all over the world. Coming to gestational diabetes, it is different from the regular diabetes, what we know, which occurs in the general population. Diabetes, gestational diabetes, is defined as carbohydrate intolerance with the onset of pregnancy or recognized during pregnancy. And then it is irrespective of the diet and insulin, we call it as gestational diabetes. As I earlier told you, diabetes is a major public health problem in India. The prevalence of diabetes ranges from 4.6% to 14% in urban areas, whereas in rural areas it is 1.7% to 13.5%. That means to say, GDM is more common in the urban areas rather than the rural areas. In India, it's estimated that about 4 million pregnant women are affected by GDM. So across the India, the prevalence varies from 3.8% to 41%. That means to say, from the provinces to provinces, that from state to state, the prevalence differs. So for this, we should screen all pregnant women for GDM. GDM poses serious risks to the baby and the mother. So we'll start with the baby. Baby can have minor or major ill effects. One minor ill effects or minor risks are macrosomia. That means the baby will be bigger than the normal. So we define macrosomia as the birth weight of the baby more than 4 kg. And the incidence of cesarean deliveries, operative vaginal deliveries are more common with this diabetes. And you must have heard about shoulder dystocia is one of the most complications of GDM. Coming to the major risks, anomalies are more common with gestational diabetes, like central nervous system anomalies, heart diseases, respiratory diseases. So many anomalies are with gestational diabetes. Not only the baby, the mother also has got so many problems like polyhydramnios, hypertension, preeclampsia and eclampsia, abruptio placenta, preterm labor, cesarean delivery, and postpartum hemorrhage. So, gestational diabetes is associated with increased maternal and fetal morbidity and mortality. So, we have to screen. So, how to screen? There are so many screening procedures, screening methods available all over the world. One step approach is there, two step approach is there. What is this one step approach? So, it's performing a oral glucose tolerance test with 75 grams glucose. So how we have to do is give the patient 75 grams glucose. Then after 1 hour, 2 hour, you take the blood sample. So you are taking fasting 1 hour and 2 hour postprandial blood samples. If the fasting blood sugar is more than 92, 1 hour sample is more than 180, and 2 hour is 153, it is diagnosed as GDM. This is one step approach. There is one more screening test, that is two-step approach. What is this two-step? In the step 1, you are performing a 50 grams oral glucose challenge test. That means you are giving 50 grams of glucose to the patient and measure the plasma glucose after 1 hour. And if 1 hour sample is more than 140, then you are proceeding to the next step. What is the step 2? Step 2 is nothing but doing a 100 gram oral glucose tolerance test, what we do normally in the general population. After obtaining fasting plasma glucose, you have to administer 100 grams of glucose to the patient, then obtain 1 hour, 2 hour, and 3 hour plasma glucose. And diagnosis of GDM is made if 2 or more of the plasma values are met or exceeded. There are two systems. One is Carpenter-Custon thresholds are there. In this threshold, fasting if it is more than 95, 1 hour if it is more than 180, 2 hour it's more than 155, and 3 hour 140. Any of the two values, remember, any of the two values are met or exceeded, then we call it GDM. The NDDG criteria is little different. So fasting is 105, 1 hour is 190, 2 hour is 165, and 3 hour is 145. Here also, 2 or more the values should be equal or exceeding. So remember, in these tests, two values are necessary. So it's very, very confusing. There are 3 tests I told. First, one step, that ends 2 step. In the 2 step, there are Carpenter-Custon and then NDDG criteria. So we have one more test. So that's why in India, the Diabetes in Pregnancy Study Group of India, they recommended only simple, cost-effective, doable community screening test. What is this test? Here you are giving 75 grams of glucose to the pregnant woman, irrespective of whether she has fed or not, and then obtain one sample after 2 hours and estimate the plasma glucose by glucose oxidase and peroxidase method. And if the value is 140 milligrams or more, she is diagnosed as GDM. So now we have got 4 things in our hand. One step, 2 step. In that, there are 2 criteria. The third one is the TIPSIS test. So there are 4 tests I just mentioned. So all these tests, we'll come to that later, which one is better. Now we have to see whether we have to screen all the pregnant women or only selective screening. Selective screening means screening the pregnant women who have got risk factors. I'll come to the risk factor a little later. So universal screening means we are screening all the pregnant women irrespective of whether they have got risk factors or not. So coming to the risk factors, one is the age. If the age of the pregnant woman is more than 25 years and the body mass index is more than 25 and she is of ethnicity, that is she is Indian, or there is a family history of diabetes, or she herself had a diabetes in the previous pregnancy, and then history of diabetes in first degree relatives. So these are all the risk factors. If the risk factors are there, are we going to do the screening? So whether we should do screening for only people who have got these risk factors, or we have to do for all the pregnant women. So we advocate universal screening. The reason for advocating universal screening because it detects more cases and improves the maternal and neonatal prognosis. One more thing we should remember, more than 50% of the pregnant women who develop GDM will not have any risk factor. So if you just stick on to only screen the people with a risk factor, that means you are going to miss more than 50% of the gestational diabetes. And one more thing, universal screening is essential because Indians are at more risk of developing diabetes. So for these reasons, in India, universal screening is adopted. The prevalence of GDM in South India, I'm telling actually, is around 16.55%. This work is done by Professor Sheshaya from Chennai. So as I told, Indian women are 11 times more increased risk of developing diabetes in pregnancy. So now we come to the point which I told about the 4 tests. So all we need to do is follow is only one, because if there are many tests, it's very, very difficult which one to follow. So better stick on to one step which we advocate. The DIPSI method is the one that we recommend for the screening of diabetes in pregnancy in India. The advantages why we recommend this is because it is very simple, economical, and feasible. That means it's cost effective also. Then how to do this test? It's very simple. When a pregnant woman comes to the antenatal clinic, you do the preliminary examination, then you give her 75 grams of oral glucose load, either in the fasting or even if it is she has come with a breakfast also, it doesn't matter. So this 75 grams glucose should be dissolved in 300 ml of water and ask the pregnant woman to drink it very, very slowly. Because we know if she drinks it fast, she vomits. Will be all these sugary things will cause nausea and vomiting. So she has to drink it slowly and she has to restrict her work and she has to take rest. And after 2 hours of ingestion of the 75 grams glucose, a venous sample is collected and the plasma glucose estimation is done by glucose oxidase and peroxidase method. We diagnose GDM if the 2-hour plasma glucose is equal to or more than 140 milligrams. So it is diagnosed. Once we get this value, we say that this woman has got gestational diabetes mellitus. So glucose, how to prepare this glucose solution? 75 grams packets are available for this purpose, but it may not be available in all the places. If it is not available, don't worry. You get the 100 grams packet that's available easily in the market. Take 5 teaspoonful, not heaped one, from that, and it will come to 75 grams glucose. So the advantages of this one step 75 grams oral glucose tolerance is it is suitable for Indian settings. It saves time, it saves cost, it avoids repeated visits, and it reduces repeated invasive sampling. Only one blood is drawn, 2 ml blood is drawn. So on the top of it, the government of India has adopted this test and then accepted, and even Foxy also has recommended this DIPSI test. Now the question comes, when we should screen during antenatal period? So it's better to screen in the first trimester. If it is negative, then go for screening at 24 to 28 weeks. And then if it is negative at that time also, then you do the last screening at 32 weeks. So why we should do early screening? What are the benefits of early testing? So if you do the testing in the first trimester itself, you will be picking up the type 2 diabetes which are unrecognized. That means a woman who is already diabetic, but she doesn't know diabetes and she has become pregnant. So you'll pick up that patient also. And then one more thing we should remember, the fetal pancreas starts secreting insulin. So if the and it responds to maternal hyperglycemia. So if the maternal hyperglycemia is there in the first few weeks of pregnancy, up to 16 weeks before she is diagnosed, so hyperinsulinemia in the fetus also will be there. So this insulin will leads to accelerated growth in the fetus and the fetus become macrosomic. So it's better to screen in the first visit itself. As I told, if it is negative in the first trimester and do the screening, repeat the screening at 24 to 28 weeks, or and if it is negative at that time also, do it around 32 to 34 weeks. Coming to hemoglobin A1C, what is the importance of hemoglobin A1C? Hemoglobin A1C measures the glucose in the previous 8 to 10 weeks. So you can, if you do this test, hemoglobin A1C estimation in the first trimester, we will know whether she is already diabetic or not. The value are, if it is 5.3, less than 5.3, it is normal. If it is more than 6, it is pre-gestational diabetes. So once you diagnose the GDM, then you have to manage it. So what are the management options? You can manage the GDM with medical nutrition therapy and then pharmacological interventions like oral hypoglycemic agents and insulin. So what the objective of management is, you should have a good diabetic control and you should have a good antepartum fetal surveillance and you should deliver the patient at the appropriate time and then you should give the optimum neonatal support. The goal, the success of the treatment depends upon how you achieve the target blood sugar levels. The target blood sugar levels are the fasting between 80 to 120 and 2-hour postprandial is between 110 and 120. Coming to the medical nutritional therapy, this is the first treatment we advocate. So it's a carbohydrate controlled meal plan that promotes adequate nutrition to the patient with appropriate weight gain and normoglycemia, and also it avoids ketosis, most important, and it's a self-management therapy. So the principles are all the GDM women should receive nutritional counseling and the meal plan should be adequate, should provide adequate kilocalories and the nutrients to the pregnant woman. So diet should, carbohydrate should be limited to 50 to 60%, proteins around 20%, and then fats 30 to 40%. We should know the expected weight gain in pregnancy normally. In a normal weight patient, we expect around 10 to 12 kg by term. This should be changed to overweight and obese pregnant woman. A overweight woman, the weight gain should be restricted to 8 to 10 kg, and then for obese woman, it should be less than 8 kg. So the calorie requirement depends upon the age, activity, pre-pregnancy weight, and the stage of pregnancy. One more thing we should remember is calorie counting. That means once we count how much calories a pregnant woman needs, that should be given in frequent intervals. We call it a split food. For example, split breakfast. Breakfast, for example, if you are giving 4 idlis, if patient needs 4 idlis for the breakfast, instead of giving 4 idlis together at 8 a.m., you must give 2 idlis in the morning and then 8 o'clock, and then after 2 hours, another 2 idlis should be given. By giving this, by following this type of thing, then immediate hyperglycemia is avoided. Like that, you have to split the lunch as well as the breakfast. So what we normally advocate is 3 meals and 3 snacks. So this is the caloric requirement. An ideal body weight pregnant woman requires 30 kilocalories per day. Overweight pregnant woman needs 24 kilocalories per day. A obese woman requires 12 to 15 kilocalories per day. So according to the weight of the patient, you have to calculate the calorie requirement and then divide this calorie requirement as the calorie count I just mentioned. So monitoring goals of this medical nutrition therapy is to attain the blood glucose fasting less than 90 and then postprandial less than 120. This is the goal. 90% of the pregnant women with the GDM can be managed with medical nutrition therapy. What about exercise? Exercise also helps in reducing the blood sugar levels. So 15 to 20 minutes of exercise is useful for the patient. And then you should advise the patient to do such type of exercises where she should not lose her balance and falls and then get hurt. So we usually advise walking, swimming, or stationary cycling. Upper body exercises can be advocated to pregnant women. 15 to 30 minutes, 5 to 7 days per week is well enough. You have started your medical nutrition therapy and also you have advocated exercise also. How long to wait? We usually wait for 2 weeks for the blood sugars to come to normal. If it doesn't come to normal within 2 weeks, then we think of other management, that is pharmacological intervention. So till 28 weeks of pregnancy, both fasting and postprandial sugar should be done once a month. After 32 weeks, it should be done more frequently. In high-risk cases, it should be more frequent with self-monitoring blood glucose. So as I said earlier, wait for 2 weeks with a medical nutrition therapy. If you fail to achieve the glycemic control, means if the fasting is more than 90 and then postprandial is more than 120, then you should start pharmacological interventions. The pharmacological intervention, next you usually think of oral hypoglycemic agents. So 2 oral hypoglycemic agents that are recommended during pregnancy for the management of GDM are glyburide and metformin. Glyburide is a second generation sulfonylurea. Metformin is a bigonide. The advantage of oral hypoglycemic agents are lower cost, ease of administration, and better patient compliance. So glyburide acts by enhancing the insulin secretion, and metformin acts by decreasing the hepatic glucose production and intestinal absorption of glucose. The glyburide is given in the dose of 1.25 milligrams to 20 milligrams per day. Metformin is given in the dose of 500 to 2500 milligrams per day in divided doses. Another oral hypoglycemic agent is acarbose. Acarbose decreases the glucose absorption by inhibiting the enzymes. The dosage of acarbose is 25 milligrams per orally, 8 hourly at meals. So you are already started the oral hypoglycemic agent, but when insulin is required, when to start the insulin? As I said earlier, even with the hypoglycemic agents, if blood sugars are not under control, or if the fasting sugar is more than 120 at the time of diagnosis itself, you must think of insulin. So different types of insulins are available. The ideal insulin is to use the human insulin because they are least immunogenic. Insulin doesn't cross placenta, but the insulin antibodies due to animal source can cross the placenta and stress the beta cells and increase insulin's production in the baby and induce macrosomia. So better to go for human insulin. Commonly used are rapid acting insulin, that is Novorapid or Humalog, have been found to be safe and effective. Recently, insulin analogs like Lispro and Aspart has also been used in pregnancy. How to give insulin? You have to administer insulin as though it mimics the natural secretion of insulin in the body. That means to say, insulin should be given at breakfast, at lunch, and at dinner. So, half an hour before breakfast, half an hour before lunch, and half an hour before dinner, you have to give insulin. In some women, we have seen that in the morning when we do FBS, there is morning hyperglycemia is there. So to control morning hyperglycemia, you have to give an intermediate acting insulin at bedtime. So this is normally this type of treatment can be done. Or you can go for the other method, that is a mixture. A mixture, combination of short acting and intermediate acting insulin. So in the ratio of 30 to 70, you give the mixture in the morning. So in the evening, you have to give 50 is to 50. That means equal amount of short acting and intermediate acting insulin. So these two ways you can give insulin according to the choice. So traditional management of GDM includes first diet, then diet and exercise. Next, if it is uncontrolled, then diet, exercise and insulin. This is regarding control of diabetes, hyperglycemia. What about the obstetric management? We have to look at the baby also. Though regular whatever we are doing, we have to do it. Apart from that, we have to fetal monitoring has to be done through the scan. So ultrasound scan is done at 18 to 20 weeks, focusing on the anomalies in the spine, the skull, kidney, and the heart, because anomalies of spine, kidney, skull, and heart are common in GDM. Then echocardiography, fetal echocardiography should be done at 22, 24 weeks, which allows all the four chambers of the heart to be viewed. From 26 weeks onwards, fetal growth and Leica volume has to be done every 2 to 3 weeks in order to identify fetal macrosomia at the earliest. So, fetal abdominal circumference provides the baseline for the serial measurement, which gives growth acceleration or restrictions. Fetal monitoring is also equally important. Coming to when to deliver these GDM patients, the NICE guidelines suggest that pregnant women with diabetes who have normally grown fetus can be offered elective birth through induction of labor or cesarean section after completing 38 weeks. There is no point in delivering earlier if everything is normal. Other studies also same. If there is any evidence of macrosomia, polyhydramnia, or poor metabolic control, then you have to think of delivering them early. So, continuation of pregnancy in uncomplicated GDM patients to full term is acceptable, provided that the indications from the fetal monitoring are reassuring. Coming to the management of labor, how we are going to manage labor. A woman with insulin, pregnant woman GDM on insulin treatment, you have to stop insulin on the previous day. That means the short acting insulin you are giving 3 times, then the intermediate acting insulin which you are giving at bedtime, you have to give. Don't skip that one. But the morning dose of insulin should not be given. You start an IV infusion of normal saline. Once the active labor starts, or the glucose level decreases to 70 milligrams per deciliter, then change the infusion from normal saline to 5% dextrose and deliver the insulin, the infusion at 100 to 150 ml per hour. You check the glucose every hour. And then regular insulin should be administered through IV route at the rate of 1.25 units per hour if the glucose level exceeds 100 milligrams per deciliter. So this is the management of diabetes during labor. Coming to the postpartum period, after delivery, what we are supposed to do? For GDM, no immediate postpartum testing is required. We should remember most of the GDM diagnosed in the third trimester will resolve rapidly after the delivery. So there is no point or no necessary of doing blood sugar levels in the postpartum period. But you have to do GTT, that is glucose tolerance test, 75 grams glucose tolerance test after 6 weeks. That means at the end of the postpartum, you have to do the GTT. If necessary, that means if the GTT is abnormal at that time, then you have to do this repeat test GTT at 6 months and annually every year. We should remember GDM recurs approximately in 50% of the pregnant women in the subsequent pregnancies. And there is also the risk of type 2 diabetes for a GDM woman. And then if she is become overweight, it is twofold increase in the risk of developing type 2 diabetes. So WHO recommends when you do a glucose tolerance test after 6 weeks, if the fasting is more than 126 and then postprandial is more than 200, you classify that woman or you call that woman as a diabetic woman. If it is less than that, it is called as impaired glucose tolerance. And if the 2-hour glucose is less than 140, she is non-diabetic. What about the baby? The baby requires NIC, that is neonatal intensive care, or special care to monitor blood glucose for 48 hours. Every hourly, first hourly and then 2 hourly, then 4th hourly and 8th hourly, the blood sugar, baby's blood sugar has to be done. And you should advocate the early breastfeeding because to prevent fetal hypoglycemia, early breastfeeding is advocated. And you should do the hematocrit at 1 hour and at 24 hours. Now we have know what is GDM, what is its problem, what it causes, what are the problems, maternal morbidity, mortality. Can we reduce or prevent GDM? Studies are being conducted with the role of myoinositol and dihydroinositol in reducing the incidence of GDM in women with no risk factors. There is an ongoing randomized double-blind multicentric study regarding this. And our center, I am happy to say that our center was one of the centers for this. So the selection criteria was a pregnant woman without any risk factors. Initial OGCT result was negative. Those were included. Then patients were administered myoinositol, dihydroinositol in the ratio 40:1, 5 grams twice daily from 16-week onwards. And then 75 grams OGCT was repeated at 28 weeks because it is at that time the GDM is recognized. So the results were very, very encouraging. There was a significant reduction in the pregnant woman getting GDM. More than 50% of the pregnant women didn't get GDM compared to the women who didn't receive this myoinositol and dihydroinositol. So administration of myoinositol, dihydroinositol may be recommended to reduce the incidence of GDM. It may not prevent, but definitely it reduces the incidence of GDM. However, larger studies are recommended. The first study was a pilot study, and then pilot study is giving encouraging results. So larger studies are planned and they are going on. To conclude, gestational diabetes offers an important opportunity for the development, testing, and implementation of clinical strategies for the diabetes prevention. The best way to take care of future generation is to begin with unborn babies. So obstetrician should screen all pregnant women for GDM and manage hyperglycemia optimally. I thank the Shield Healthcare for giving me this opportunity and share my knowledge about GDM and then the new look at GDM, that is today's topic. And then I immensely thank all of you who are patiently attending and listening and watching this particular program. Thank you so much. Thank you once again.
Thank you, sir. Thank you very much for this excellent presentation of yours, as always. Sir, we need to wait for the queries because as of now, can we just wait for a couple of minutes and
No, okay,
let us
okay, sir. No problem, no
the
problem.
participant to post in their queries, and I will come back to you, sir. Right.
Okay,
Thank you,
okay,
sir.
okay, sir.
So as of now, sir, there is no such query. I think your presentation has been really very no, lucid and complete. So I'm not finding any queries. But sir, I have certain queries.
Yeah,
I
yeah,
have,
yeah.
sir,
Please, please.
is there any myth regarding PCOS, GDM, Nexus kind of thing? I mean, that's an out of the way question.
It's
Uh,
not a myth, sir. It's a true, actually. See, women with a PCOS are being treated and they become pregnant. Definitely, the incidence of GDM in them is high compared to the non-PCOS patients.
okay. So it's not a myth. Actually, it's a fact. So
It's a fact.
patients.
It's a fact.
Okay. So I mean, during your clinical experiences, any queries, concern of the patients
Mhm.
regarding the treatment while no, they are having the treatment of GDM? Any queries which regarding the nutritionals like myoinositol? Any queries in the safety? Anything which they have asked during this tenure?
No, no. Actually, we should counsel the patients properly and then tell the importance of myoinositol and D-inositol. Off the record, I'm telling I have been a part of this study, and then once the results have come out, from that day one, I have in my personal practice, I am advocating, I am dispensing the myoinositol and D-inositol from 16th week onwards, and then the incidence of GTM is very, very low in my practice. And
Okay.
then one more thing, it improves the fetal growth also.
Right.
Yeah, birth weight also increases.
Right. So there is one query which has been posted by Dr. Suchira Jain. Madam has mentioned that it's very informative session. Should myoinositol be given after 16 week in general with a history of GDM in previous pregnancy?
It should be given.
Yeah. So I repeat the question, sir.
Yeah,
It should be given, right?
yeah, should be given because previous history of GDM. So these are the people who require actually. Hmm. So she should be administered or recommended the myoinositol and decaroinositol in this pregnancy from 16 weeks onwards.
Mhm. Okay. So I think this was the only question which has come. I think we can, if you sir allow maybe one more minute, we can give to the audience.
Okay, sir.
They
Okay.
are, they are posting their queries.
Okay, sir.
Maybe one more question from my side till the time they give
Okay.
their comments.
You are most welcome, sir.
Uh, Sir, what is the ideal regimen along with myoinositol and dechiroinositol in the treatment of GDM? I mean, as far as your feedback is concerned.
I
As in
didn't.
combination, I mean, with MI and DCI, what should be added along with MI DCI for prevention of
No,
GDM?
I don't feel any addition for that. It should be given plain. You mean to say any other vitamin D or something like that?
Right, right.
Yeah. It's recommended.
Okay,
You can give vitamin D also because you should see to it that you should give the vitamin D in the recommended allowance. Because these days what I don't give vitamin D because all these calcium tablets are with vitamin D. Most of the
okay,
calcium tablets are with the vitamin D. So this myoinositol and dechiroinositol sachets, if they also contain vitamin D, there may be a problem because plain calciums are not that easily available. So all
okay,
these pharmaceutical companies, they have added vitamin D and then so many other combinations. So I think addition of your suggestion is really good. Addition of vitamin D also is really helpful for the patient. They need it. Pregnant
right.
women also need it. Yeah.
Any other ingredient in your, I mean, as per your suggestion? Any other ingredient along with MIDCA?
Yeah, and what I would feel is actually the studies, some papers are also there regarding that L-argine.
Okay,
Yeah. See, the L-argine administration is going to prevent some percentage of hypertension actually.
okay, okay,
Preeclampsia, reduction, there is a reduction in preeclampsia. So L-argine can be added. I don't know whether it's compatible with the same myoinositol, dechiroinositol. It can be given separately.
okay, okay,
I give separate.
okay. So it's along, I mean, for a patient who is getting a prescription of GDM, definitely L-argine is on the prescription.
I
Okay,
agree. Yeah.
right, right. Is there any other?
Because diabetes and hypertension are the two major killers of maternal morbidity and mortality. That's why. So we have to take care of that. Hypertension is also equally prevalent. One
Right,
in 10 pregnant women are hypertensive.
right, right.
Mhm.
Chitrikala, do you have any other queries? Because I'm not seeing any other query right now.
Yes, only one. This one first.
Right. Apart from the compliments, definitely, sir, as mentioned by Dr. Suchira Jain, also there are many messages which have come
Sir,
from.
only compliment, no criticism also I welcome.
So criticism generally don't come when we have faculty like you. I mean, it is always we want to learn from esteemed faculty like you. They will know. They will always thank you, and probably they will ask you questions.
Yeah.
So I think with that, sir, because I'm not finding any other question, and almost we are on the verge of closure for the day.
Yes.
With your permission, can we close the webinar for today?
Yeah.
Thank you, sir. Once again, thank you very much for making this webinar very
Before
informative.
closing, I will put a word also. I am very happy to get associated with all your academic activities.
Thank you, sir. Thank you very
Future
much.
also.
We will continue to take your support and build our Shield Connect so that many doctors will learn from you. We will all gain the
Yes,
wisdom from you in the
yes,
field of GDM and PCOS.
yes.
Thank you, all doctors. Thank you, respected sir, for
Okay.
today's webinar. And now you can.